For the longest time, the name Bifidobacterium has been basically synonymous with health, right? We see it in yogurt, we're told to take it as a probiotic, and we think of it as this cornerstone of a healthy gut. But for those of us in medical microbiology, that story is starting to change. So today, we're going to pull back the curtain on how this hallmark of health can, when the stars align just wrong, become a really dangerous opportunistic pathogen. Now, just so you know, everything we're about to dig into is grounded in solid clinical literature, which I pulled together using Gemini Deep Search. And for all of you who want to really geek out and go to the source, I've linked the full notebook with all the primary references for you to explore. Okay, so here's our game plan. First, we're going to tackle this probiotic paradox. Then we'll head to the lab bench to figure out how to identify the culprit. After that, we'll go to the bedside to see what happens when good bacteria attack. We'll then wrestle with the huge problem of treatment without clear guidelines. And finally, we'll wrap up with how to handle these things safely in the hospital to prevent this from happening in the first place. So let's dive right in. Section 1, the probiotic paradox. And this is really all about a huge shift in thinking we need to make when a product that's literally designed for health becomes a hospital-acquired or iatrogenic threat. And here is the paradox in a nutshell. On one hand, you've got the myth, the popular idea that Bifidobacterium is only a good guy. But then there's the reality for us in the clinic, that it can be a rare but really significant opportunistic pathogen that causes life-threatening bloodstream infections. But here's the key. It only happens when the host's defenses are seriously down. It's this two-sided coin that makes it so critical for us to understand. Okay, so if we suspect Bifidobacterium is the bad guy, how do we actually nail it down in the lab? Let's head to the bench for Section 2 and talk identification. Under the microscope, it's a classic gram-positive rod. It's famous for those textbook bifid shapes, the Y's and V's, these branched-looking rods. But here's the kicker, and this is so important. That classic look is not guaranteed at all. Depending on the species, the culture conditions, you might just be looking at simple straight or curved rods. So the takeaway, you absolutely cannot hang your hat on that textbook morphology alone. Now, what's really fascinating here is how you can almost trace the infection back to the bug's day job. Look at Bifidobacterium longum, super common in adult probiotics, and what do you know? It's the #1 cause of probiotic sepsis in neonates. Or Bifidobacterium breve, a normal resident of the infant gut, but it shows up in bacteremia when that gut barrier is broken. And then there's Bifidobacterium dentium, from the mouth, which often pops up in adult bloodstream infections, pointing you right to a possible dental source. Growing the thing isn't quick. It's a strict anaerobe, and it takes its sweet time. We're talking 48 to 72 hours. Biochemically, it's catalase and oxidase negative. The really unique marker, though, is the fructose 6-phosphate phosphoketolase enzyme, or XFFP. That's a key identifier for the whole genus. And this part is so important for anyone doing molecular ID. Your standard 16S sequencing is often not good enough to tell the species apart. For a definitive species-level ID, you really have to use something more robust, like multi-locus sequence analysis, or MLSA. Okay, so we figured out how to spot it in the lab. But what does it actually do to our patients? Let's move into Section 3 and find out what happens when these good bacteria go bad. The thing to remember is, this isn't some super aggressive primary pathogen. No, it's an opportunist. It waits for the perfect storm. And these are the storm clouds it looks for. A severely weakened immune system from something like chemo, a breach in the gut wall, say after surgery or in a premature baby with necrotizing enterocolitis, the very young or the very old, and of course any indwelling plastic, like a central line that it can grab onto. And if you ever needed a smoking gun, this is it. This isn't just a theory, folks. We have the receipts. Researchers have literally taken the Bifidobacterium out of an infant's blood, sequenced its entire genome, and found that it is a perfect 100% genetic match to the strain inside the probiotic supplement they were being given. I mean, it doesn't get any clearer than that. That is a direct, forensically proven link from the product to the patient's bloodstream. So what does this look like at the bedside? Well, the big one is bacteremia and sepsis, usually happening when bacteria translocate across a leaky gut. We've just seen the most heartbreaking example, probiotic-associated sepsis in preemies. It can also cause more localized problems, like dental abscesses. But no matter the infection, please remember this: antibiotics are not enough. The absolute key here is source control. You have to drain that abscess. You have to remove that infected line. It is paramount. Okay, and this brings us to what is honestly the biggest headache for all of us:
treatment. Section 4 is all about the antimicrobial guideline gap, and it's a huge problem for both the lab and the clinicians. I want this to sink in for a second. The European Committee on Antimicrobial Susceptibility Testing, EUCAST, has established exactly 0 clinical breakpoints for Bifidobacterium species. That means when we run a susceptibility test, we have no official S, I, or R interpretation to give. We are essentially flying blind.
So if we don't have official breakpoints, what do? We have to fall back on what we know is hardwired into this bacteria's DNA, its intrinsic resistance. This isn't something it picks up on a plasmid. This is a fundamental part of its physiology. For instance, it might lack the right doorway to even let an antibiotic into the cell, which means that drug will never, ever work. And this slide basically turns that concept into a practical guide. Think of it like a traffic light. Red light, full stop. All aminoglycosides, like gentamicin. They are intrinsically resistant, period. Don't use them. Yellow light, be extremely cautious with metronidazole. It's a go-to for so many anaerobes, but here it's a coin toss, with resistance in almost 40% of isolates. Green light, these are generally your safer bets. Broad-spectrum beta-lactams, carbapenems, clindamycin. But even here, you absolutely must be guided by the MIC value from the lab. So since we don't have a specific playbook for the bug itself, we have to look at the playbook for the syndrome, a severe anaerobic infection. And what you see is that both the international IDSA and the Dutch SWAB guidelines point to the same heavy hitters for empiric therapy, piperacillin tazobactam or a carbapenem like meropenem. And the Dutch guidelines add a really crucial warning here. That common combo of ceftriaxone plus metronidazole, it's a risky bet. If your bug happens to be metronidazole resistant, you've just lost all of your anaerobic coverage.
Now, this is absolutely critical, because when we're talking about kids, especially those tiny neonates who are most at risk, you can't just guess the dosing. It's not a simple scale down of the adult dose. Looking at the Dutch pediatric formulary, you can see just how specific this gets. A term neonate could get up to 120 milligrams per kilogram per day of meropenem, and look at clindamycin. The dose can literally double once a child is over a month old. Getting these details right is vital.
Okay, so all of this leads us to the final and maybe most important section. If these probiotics are the source of some of these iatrogenic infections, what are we going to do about it? Let's talk infection prevention and control. First things first, who should never get a probiotic in the hospital? Full stop. That's anyone who's severely immunocompromised, anyone whose gut barrier is shot, and critically ill patients, especially those with central lines or other devices. In these patients, the risk of causing a life-threatening infection just blows any potential benefit out of the water. And for the very few patients where it might be considered, we have to handle these things with the respect they deserve. It's not yogurt, it's a live biotherapeutic. So here's a simple protocol. 1. Treat it like a drug. It goes through the pharmacy. 2. Use aseptic technique. Wear gloves, prep it in a clean area. 3. Be careful opening these powders. You don't want a cloud of live bacteria floating around. And 4, when you give it, be extremely careful not to contaminate things like central line hubs. So yeah, looking ahead, there's still a ton of work to do. We are desperate for official EUCAST breakpoints. We need huge prospective safety trials in these high-risk groups. We should probably be doing routine genomic surveillance on the commercial products themselves. And really, every single hospital needs to have a clear, evidence-based policy on how and if they use these things. And that really leaves us with this final thought. Probiotics are just the tip of the iceberg in a new era of live biotherapeutics. So the big question for all of us is this. As we start prescribing living organisms as medicine, how are our labs, our protocols, and our own vigilance going to evolve to keep our most vulnerable patients safe? If you found this deep dive useful, please subscribe for more explainers on clinical microbiology. And I really do want to hear from you. Have you ever seen a case of Bifidobacterium bacteremia? What's your hospital's policy on probiotics? Drop your experiences and thoughts in the comments below. Thanks so much for watching.